30 years old gentleman who's resident of Daryaganj, New Delhi, and is a shopkeeper by occupation. He presented to the OPD of LNJP Hospital on 9th of July 2021, and the history was given by himself, and it seems to be reliable. So the patient presented with chief complaint.
Jyotsna, when you are saying
Yes,
that I am presenting the case of Mr. X, that Mr. X is your patient.
Yes, sir.
Okay, so you have to say it like this, that I am going to present the case of my patient, Mr. X. Okay.
Okay, sir.
So listen, it looks more nice when you say that this is my patient and his name is so and so, and then the demographic profile. When in an examination,
Yes.
when you are going to present it like this, so you have to say that this is my patient. Okay.
Okay,
So
sir.
go ahead. Go ahead. Next slide.
So my patient presented with the chief complaints of puffiness of the eyes and face for 1 month, swelling of the lower limbs and upper limbs bilateral for 3 weeks, abdominal distension and external genitalia swelling for 2 weeks, and reduced urine output for 1 week. History? Yes, sir.
Now you are audible.
Okay. Sir, should I repeat the previous slide?
Yes, you should repeat the previous slide because you are not audible at the time.
Okay, sir.
Yes.
So the chief complaints of the patient are puffiness of the eyes and face for 1 month, swelling of the lower limbs and upper limbs bilateral for 3 weeks, abdominal distension and swelling of the external genitalia for 2 weeks, and reduced urine output for 1 week.
Okay, go ahead.
So history of presenting illness. The patient was apparently well 1 month back when he first noticed there was puffiness of his face, especially around the eyes. So the swelling was insidious in onset. It gradually progressed initially from the preorbital area around the eyes, and now it involves the whole face. And the swelling was seen more during the morning hours, and then it decreased as the day progressed.
Okay. Continue.
Then the patient also noticed swelling of bilateral upper and lower limbs 3 weeks ago. This swelling was also insidious in onset. It was gradually progressive. It started in the upper limbs from hands up till the elbow, and in the lower limbs from feet to the knee. And it was more during the morning hours and decreased as the day progressed.
Okay, continue.
The patient noticed generalized distension of the abdomen 2 weeks ago, which was insidious in onset, gradually progressive, and then it also involved the external genitalia. There was scrotal swelling which was seen. Then the patient noticed that there was a reduction in the frequency and amount of urine that he passed. Initially, he used to pass 6 to 8 times per day, but presently he is passing urine only 3 to 4 times per day, which is also reduced in amount, and he mentions that it is frothy in nature.
Okay.
So now we come to the negative history. So there's no history of breathlessness on exertion or sudden waking up during the night due to breathlessness. There's no history of bloody vomiting, black tarry stools, jaundice few years back, or blood transfusion. There's no history of decrease in appetite, fishy or metallic taste, and difficulty in concentrating. There's no history of chronic diarrhea. There's no history of sore throat, fever, or genital lesions. There's no history of drug intake like penicillamine or anti-snake venom. There's no history of rash on the body or joint pain. There's no history of hemoptysis. There's no history of recent fractures or postural hypotension or syncope.
So why have you taken this history of recent fractures?
Sir, because it is a complication of nephrotic syndrome that vitamin D can decrease, which can lead to weaker bones and weaker bones.
Okay, and then why have you taken history of hemoptysis?
So because ANASARCA can present with hydrothorax. No, this
So
is
hydrothorax never causes hemoptysis. Why have you taken history of hemoptysis? What was in your mind while taking history of hemoptysis?
so the in good pasture syndrome, there's involvement of both the kidneys and the lungs. So to rule out that, I have taken the history of hemoptysis.
So what is a good pasture syndrome? What is good pasture syndrome?
So in good pasture syndrome, there's antibodies against collagen 4, which is present in the basement membrane, which is present in both the glomerulus and the uh, respiratory system alveoli. So if good pasture syndrome, both are damaged. So we can see symptoms of kidney disease as well as lung disease.
Okay. So you have in mind good pasture syndrome because this is case of sarca and that's why you have taken history of hemoptysis. And you should have taken another history of lung involvement. It's not only that the patient of good pasture syndrome will present only with hemoptysis. As far as the lung is concerned, he will have some other histories also.
So there's no history of suggestive of any lung involvement.
What history you have taken there? Apart from hemoptysis, what else you have taken?
So
Hemoptysis, yes, good passion syndrome may have patients may have hemoptysis, but what are the other symptoms, lung symptoms which can come in a case of good passion syndrome?
so difficulty in breathing, breathlessness.
Okay, that you have asked.
Yes, sir.
Cough, dry cough.
Yes, sir. Dry cough also can be there.
Yes, yes. So that is more important.
Okay.
Hemoptysis तो बहुत late stage में होता है.
Hmm.
If you have in a mind, so that this patient might be having good pasture syndrome, so might be having lung involvement. So ask the pulmonary symptom first, like cough, then we'll go to the hemoptysis.
Okay,
Just
sir.
okay.
Yes, sir. I'll ask both the histories.
Okay, go ahead.
Okay. So now past history, the patient is not a known case of diabetes or hypertension, and there's no history of tuberculosis or exposure to a case of tuberculosis. Then
Okay.
personal history, the patient has normal bowel habits, normal sleep pattern. The patient does not have alcohol or drug addictions, and he does not have any high risk sexual behaviors.
Okay.
In family history, there is no history of similar complaint or episode in the family members.
Okay.
Now, my summary and differential diagnosis. My patient, Mr. X, 30 years old gentleman, presented to the OPD with generalized swelling of the body ANASARCA, which progressed from facial puffiness to bilateral lower and upper limbs and decreased in flow of the urine. He is probably a case of primary nephrotic syndrome due to focal segmental glomerulosclerosis or membranous glomerulonephritis without complications.
You don't have to say this much in differential diagnosis. This is not differential diagnosis. This is you are
So this was
presenting as
this part also.
this you are saying only the diagnosis and that too the histopath report also. You are saying histopathology also simultaneously. No, no, this is not done. Okay, the upper one that you have write the upper paragraph. You have write the that is a summary.
Yes,
Yeah.
sir.
The lower paragraph which you have written, it should include more diseases rather than you saying focal segmental. This can be membranous, this can be MCD, this can be FSGS, this can be anything. Okay,
So
but the diagnosis is nephrotic syndrome. Other
yes.
apart from a nephrotic syndrome, what else you can
So other
see in
than
this?
nephrotic syndrome, there are many causes which can cause anasarca, but I have mostly ruled them out. Like anasarca can be due to uh, heart failure, but I have ruled that out by the history. Then it can also be due to cirrhosis. Then other causes are nutritional deficiencies or uh,
So, so what history you have taken for the cirrhosis?
so for cirrhosis, I've in the personal history of as alcohol consumption, like it leads to
Suppose,
cirrhosis. So that history is important.
suppose this,
And other,
suppose this, suppose this patient was having Wilson's disease from the child and now have developed cirrhosis. So he is not taking alcohol, but he is cirrhotic patient.
yes, so for that I have taken the features of cirrhosis like bloody vomiting and black tarry stools, or it can cirrhosis can also develop due to hepatitis B, hepatitis infection. So I've also taken history of jaundice a few years back.
Okay. Mm,
And
okay.
so the first history, breathlessness on exertion, and PND I've taken for the cardiac cause of ANASARCA.
Okay. So, and so this is a classical case of nephrotic syndrome because started the face swelling started in the face first.
Yes,
Apart
sir.
from nephrotic syndrome, can you imagine any other? Can you name any other disease which can present like this, like facial swelling,
So maybe a case of chronic renal failure.
chronic renal failure? No,
Uh,
chronic
so,
renal
but
failure only if it is secondary to nephrotic syndrome, then only it will present like this. Hmm? Chronic
so
renal
diabetic
failure,
nephropathy can also
secondary.
present as nephrotic
Yeah,
syndrome.
which one?
Diabetic nephropathy can also present as nephrotic syndrome.
Okay, so this patient is not having diabetes. Also,
Yes.
that is diabetes will present as nephrotic syndrome. So ultimately, it is nephrotic syndrome. I am
Yes,
thinking,
sir.
I am asking you some other disease or other diagnosis of facial
So the
puffiness.
facial puffiness can be due to other reasons like allergic reaction, which is like uh, angioneurotic edema, and it can
Yes.
be uh, and it can be due to mixed edema, or it can be due to SVC syndrome, but that will not be to anasarca. These are the causes of facial edema in the body.
Yes. Yes. SVC syndrome. Okay, so these are the causes that SVC syndrome were. So SVC syndrome may what's the difference between a nephrotic syndrome facial puffiness and SVC syndrome puffiness? Can
So
you get me?
first, to the swelling of nephrotic syndrome is all over in the body, like first in the face, then in the legs, and then ascites. But in SVC syndrome, only upper body is involved and not the lower limbs.
Okay,
Then,
very good, very good. Now,
so
इसमें तो
so in
facial this in nephrotic syndrome, the swelling will start from the periorbital area. Okay, and
yes,
in SVC syndrome, the swelling will start from the whole face, including the neck,
yes, sir.
simultaneously. Okay, and along with dilated veins.
So and yes, so dilated neck veins and reddish congestion can occur on raising the hands. So
Yeah.
and then JVP can also be raised in uh, that SVC syndrome.
क्यों JVP क्यों raised होगा? Hmm?
सॉरी
JVP क्यों
सर,
raised होगा?
तो कार्डियक कॉज में रेज होता है. सो
Hmm.
सो डायलेटेड वेन्स और कहाँ से स्टार्ट हो रहा है एडेमा, इससे डिफरेंशिएट कर सकते हैं.
So this edema is pitting or non-pitting?
This is a pitting edema.
Repeating edema.
Yes, sir.
कैसे पता चला तुम्हें?
सर एग्जामिनेशन में चेक करा था.
हिस्ट्री में भी तो पूछ सकते हो. You can
Yes, sir.
ask in the
History.
history.
Sir,
कैसे
history में there can be features of like
क्या पूछ
sir,
सकते?
the ring in the finger fits in little snugly and उसकी वजह से निशान भी पड़ जाता है. There is pitting seen on due to the ring.
Very good. Any
Sir,
more common question? Ring is not so common. हर कोई नहीं
belt.
पहनता है. Another
Sir, belt.
bag? Slippers. Slippers everybody uses daily, morning, evening, night. Every time they use slippers. So you can ask. There are imprints of slippers on the edema.
Yes, sir.
How
Yes.
long that stays there, ना?
Okay, sir.
वो आपको इसमें हिस्ट्री लेनी चाहिए थी. What are the causes of non-pitting edema?
So basically, pitting edema is when there's fluid collection in the subcutaneous area. But a non-pitting edema can occur in causes like myxedema or angioneurotic edema or in late stages of lymphatic obstruction.
Very good, very good. Why have you taken history of this chronic diarrhea?
Protein losing enteropathy, like that can also be cause of hyperproteinemia, which can lead to ANASARCA.
Okay. So go ahead with your examination. I think the history is very straightforward in this case because that it started from the periorbital region.
Yes, sir. And
So
then it went limbs.
then afterwards it is so it's very straightforward. But you should remember all these things which I have said that.
Yes, so pitting edema is slipper use.
Okay.
So should I start with the examination?
Yes, you should start the examination now.
So general physical examination. The patient was conscious, well oriented to time, place, and person. Examination was done after due consent in supine position in a well lit room. Vitals. Pulse was 80 beats per minute in the right radial artery, regular in rhythm, good volume, normal vessel wall, no radial or radiofemoral delay. Respiratory rate was 18 per minute. BP was 126 by 82 mmHg in the right brachial artery in supine position, and the temperature was also normal, 98.6 degree Fahrenheit. Then head to toe examination. The hair look normal. There's pallor seen in the lower palpebral conjunctiva. There's no icterus. Periorbital and facial puffiness is seen. Orodental hygiene of the patient is good. JVP is not raised. No cyanosis, clubbing, palmar erythema, or lymphadenopathy is seen. Then edema is present on the bilateral upper limbs and lower limbs till the elbow and knee respectively. Pitting type. There is no gynecomastia, no spider angiomas. There is generalized abdominal distension which is seen. There are no striae on the abdomen. Umbilicus is averted. Scrotal swelling is present, and there is no sacral edema.
Okay.
Then
Continue.
system. Yes, sir.
Continue.
Then system-wise examination. In CVS, S1, S2 are present. There's no murmur or abdominal heart sound which is heard. Respiratory system, bilateral air entry is present with bilateral symmetrical chest rise and no added sounds. On abdomen, on inspection, the abdomen is uniformly distended with flanks full. All quadrants move equally with respiration. The skin looks stretched and shiny. Umbilicus is averted with transverse slit. There is no striae, distended veins, or scar marks. On head raising test, there's no divarication of the recti which is seen, and the hernial orifice look intact. On palpation, there's no local rise of temperature or tenderness. Abdominal girth is 109 centimeter. Downward displacement of umbilicus is seen. Spino-umbilical distance is equal on both sides. Fluid thrill is absent and there is no hepatosplenomegaly. On percussion, the shifting dullness is present and on auscultation, normal bowel sounds are heard. In CNS examination, there is no focal neurological deficit or higher mental functions are intact. No involuntary movements are seen. External genitalia scrotal swelling is seen with positive fluctuation test and transillumination tests and absent cuff impulse test.
Okay. So,
So now the
did your diagnosis change after the examination? What all you got in your examination? Just summarize. You got ascites, you got scrotal edema, you got pitting type edema throughout the body.
yes, sir. So there's facial edema, upper and lower limb edema, which is pitting in nature. Then there's ascites, and there's also the presence of scrotal edema, which is seen. Then there are no signs of cirrhosis or other cause which I could make out on examination. So the examination also suggests that this is a case of nephrotic syndrome.
Okay. And no signs of liver failure.
No, sir.
No signs of liver failure. Okay.
No, sir.
So your diagnosis remains same even after examination. That is nephrotic syndrome.
Yes, sir.
With a history of 1 month. Total history of 1 month.
Yes, sir.
The age of this patient? The age of this patient?
30 years old.
30 years old. Okay. So, what complications can a patient of nephrotic syndrome will have?
So, in nephrotic syndrome, if there's non-selective proteinuria, then the patient can have edema. Sorry, the patient can have anemia. Then he can also have infections, or there can be hypercoagulation, and the patient can present with portal hypertension.
Hypocoagulation or hypercoagulation?
Hypercoagulation, and the patient may present with postural hypotension, and the patient can also develop hydrothorax, which is not the case here.
Okay. Why hydrothorax develops in nephrotic syndrome patients?
So due to the same reason that edema is developing in other parts, like due to decreased protein in the serum, the oncotic pressure decreases, which can lead to hydrothorax as well as ascites or these things.
You develop bilateral or on one side?
So bilateral.
Bilateral. Okay.
Yes.
So bilateral. So rather than saying hydrothorax, you should say pleural effusions.
Okay, sir.
थर्ड स्पेस लॉस ना, जस्ट थर्ड स्पेस लॉस, उसमें
Yes.
प्लूरल effusion भी आएगा, उसमें साइटिस भी आएगा, उसमें एडिमा भी आएगा. Okay.
Yes.
So how will you investigate this patient?
So there's a set of investigations that I like to do. The complete blood count, peripheral smear, serum albumin, urine analysis, kidney function test, lipid profile, and kidney biopsy.
So in urine analysis, what will you do? Suppose this patient came to you in your OPD. Hello, doctor, can you hear me?
Yes, sir. Yes, sir.
This patient came to you in your OPD, and you want to make diagnosis there and there, then and there. What and patient will give you the urine sample. What will you do with that urine sample?
So we'll take the spot urine sample and do a dipstick test to analyze the proteinuria.
Proteinuria. The डिप्स्टिक चेक में क्या पता चलता है?
So dipstick may that if proteinuria is present or not, and if it is present, the amount of proteinuria.
Okay. So can dipstick method give you idea how much proteinuria is present? Have you seen dipsticks test dipsticks? So the box.
So I have not seen it.
तुमने कभी देखा ही नहीं वो है? वार्ड में कभी देखा नहीं तुमने? कैसा होता है?
नहीं sir.
So it gives reading in this 1 plus 2 plus 3 plus or 4
Yes.
plus. Okay, so the 4 plus or 3 plus is more than 3.
Yes
Likely
sir.
more than 3. Okay. So in urine analysis, what else you will do?
So protein analysis we'll do. Then RBCs if are present or not. We'll see for the presence of. We'll see the protein creatinine ratio, and we can also do drug testing, although it may not be required.
Okay. Drug testing.
So if the patient is a drug abuser.
Would you like to see the sediments? Any active sediments? Casts?
Yes
Written
sir.
the
Cast.
Hmm. Suppose this patient has RBC cast in his RBC cast in his
Yes.
urine analysis.
So then that the basically hematuria is seen in the case of nephritic syndrome. So
No, no, no. Hematuria is different and RBC cast is different. Both things are different. Hematuria can be because of the external injury also, like urethral injury also. But
yes sir.
RBC cast is different. So if you find RBC cast in your urine analysis, then your diagnosis will change or not, or it will still remain nephrotic syndrome.
So basically RBC
Basically,
casts. The
I'm asking
problem is
the
yes sir.
difference between nephrotic syndrome and nephritic syndrome. अगर आप difference between nephrotic and nephritic syndrome को read करोगे, तो उसमें ये कास्ट का आएगा. Active
Yes
sediments,
sir.
sediments आएंगे. Nephrotic syndrome में, nephrotic syndrome में there will not be any sediments.
So nephrotic syndrome may we'll find proteinuria is more than 3.5 grams per day. But nephritic syndrome may we can have proteinuria, but it is generally 1 to 2 grams only. And then
Very good.
RBC casts and hematuria, these are seen in nephritic syndrome and not in nephrotic syndrome. Uh, these are the main differences between the two.
Any clinically difference? Nephritic syndrome
So
patient.
the patient of nephritic will not present with so much edema.
Okay. And hypertension.
Yes, the
Nephritic syndrome.
hypertension is like it can be present in both, but it is more commonly seen with nephritic syndrome, and also dyslipidemia is seen more with the nephrotic syndrome.
Okay. Okay. So before proceeding to your kidney biopsy, what so you have done this all this workup,
Yes, sir.
and you found that the patient is having protein of 3.9 gram per day. There are just RBCs, CBC, and all that you have done. Now,
Yes, sir.
will you subject the patient for kidney biopsy,
So kidney
or
biopsy
you will
important.
like yes, infection? Well, now you have come. Infection for Hep B, HIV, syphilis. Okay.
So these are to rule out the infections which can cause the problem, and kidney biopsy is taken so that we make the exact pathological diagnosis because we have different prognosis for the different diseases. So to make the exact diagnosis and prognosis of the patient.
Would you like to do the C3 level in blood?
So C3 level is decreased in some diseases like IgA nephropathy maybe, but in the nephrotic syndrome it is generally normal, I guess.
IgA nephropathy causes nephrotic syndrome or not?
So it's mainly a cause of nephritic syndrome.
Yes. So you not require
No, sir. The complement levels are not required there.
biopsy in a case of nephrotic syndrome.
I was not able to hear the last sentence. What did you say?
What do you expect on kidney biopsy in this patient?
Okay. So in this patient the kidney biopsy showed FSGS. So we will on light might.
Leave
Yes,
the
sir.
leave the kidney biopsy report just without
Okay.
you did the biopsy, keeping in mind कि अब क्या होगा, what is the likely possibility. Suppose this patient would have been a 10-year-old boy, then the
Okay.
likely possibility is MCD.
If a child, then it is probably most commonly a minimal change disease. But in
Yes,
adults, the most common cause may be FSGS or membranous glomerulonephritis. These are the primary causes, or it may be secondary to diabetes, diabetic nephropathy. So we can make these out on kidney biopsy.
very good, very good. So how will you treat this patient? So
So,
okay.
so for the ANASARCA which has developed, we'll use diuretics. We can use both furosemide and spironolactone to maintain the potassium balance. Then for the treatment of
What is that balance? What is that balance? Furosemide and spironolactone, so that potassium balance रहे तो किस रेशियो में देते हैं?
um, so one
मतलब कितना आप furosemide दोगे, कितना आप spironolactone दोगे?
2.5 furosemide should be furosemide to spironolactone should be 2.5:1.
It's 2:5.
Yes,
It's like 40 milligram of furosemide and 100 milligram of spironolactone.
yes, sir.
So it is 2:5 is the ratio. Okay.
Yes, sir.
So you will give ACE inhibitors and
Yes,
ARB.
sir.
Why? Patient is not hypertensive. Why will you give ACE inhibitors or ARBs? These are anti-hypertensive drugs.
Sir, but these also they inhibit the RAS system, so prevent the uh, edema formation due to sodium and water retention, and uh,
Hmm.
basically they
Well,
decrease the nephropathy progression.
they reduces the
Neph-
proteinuria. They have an anti-proteinuric effect on
so
kidney.
yes, they decrease the GFR
Proteinuria.
also, so proteinuria is also decreased.
So the more the proteinuria, the more the GFR will reduce. See जब kidney से protein निकलेगा तो वो damage करके निकलेगा. Okay.
Yes, sir.
So
Yes, sir.
the longer the time the proteinuria will be there, the longer the kidney damage. So you have to
Yes, sir.
reduce the proteinuria also.
Yes,
The
sir.
one thing is the diuretics will diuretics will give the symptomatic improvement to the patient, nothing else. So for
Yes, sir.
edema, ACE inhibitors and ARBs, what they do, they have an anti-proteinuric effect. So they will reduce the
Protein
proteinuria.
damage to the kidney, which is
Yes. What are the other drugs which you can use for anti-proteinuric effect?
mm,
Name other drugs.
uh, I don't know.
So it's been given in the Harrison. You have read it, nephrotic syndrome from Harrison. It is given over there. One, you have said that ACE inhibitor ARB is very good. Then, what will you do for the hyperlipidemia?
So for hyperlipidemia, we should give statins.
You have not mentioned it over here.
Yes, I forgot to mention it. I thought, but I forgot to
Okay.
write.
So, statins are also antiproteinuric effect. Remember
Okay.
this. Okay.
Okay, sir.
Apart from this thing,
Yeah, these are
hyperlipidemia, they have an additional advantage of having antiproteinuric effect. So ACE
okay, sir.
inhibitors, if your BP is permitting, you should give in high dose. If your BP is not permitting, you should go in low dose. Okay. But statin you
Okay,
can give in moderate doses because there is hyperlipidemia. It has all the
yes, sir.
and
So it
the
will be
third
both
drug
the
is amlodipine.
okay,
Third
sir.
drug is amlodipine. Amlodipine has also mild antiproteinuric effect. So
Okay, sir.
that can be there. So what will you suggest for the diet in the patient? Will you reduce the protein intake? Will you increase the protein intake? What will you do? Or
So
protein intake normal?
in diet,
Patient
the should be decreased and protein intake should be around 0.8 to 1 grams per day, about normal only.
patient is losing so much of protein. Unless you replace it, how will you with this normal uh, protein intake? It will go. Patient is losing 4.5, 3.9 gram, 4 gram per day. And if it continues to take for a normal protein intake, then he will have severe hypoalbuminemia. Severe
So, but
hypoalbuminemia, okay, then
so but
edema,
the increased protein intake, because that will also be harmful for the patient.
that will also be
Harmful for the patient, increased protein intake.
why? Why it will be harmful? Tell me. Because then kidney will filter more and more protein.
So
Hello?
the if increased protein,
If,
then
you see, earlier there was a concept that we should replace the protein. We should give high protein diet to these patients. But then
yes,
then the studies will find out that the more we give the protein, it will more harmful for the patient.
yes,
Why
sir.
is it so? Why is it so? Because then there will be more protein in the body and kidney will filter out. And as the kidney will filter out more and more protein, it will cause more and more damage to the kidney.
Yes, sir.
Okay. So you will monitor the weight loss and you will give some immunosuppressive drugs like steroid or some other drugs depending on the case to case
Yes, sir.
basis. So these are the
Yes,
definite.
yes,
So if you don't give this immunosuppressive drugs, take it to this
yes,
patient. Just you limit remove the steroid. You give the diuretics, ACE inhibitor, diet restriction, all that. Steroid and immunosuppressive drug you will not give. So what will happen to this patient then? Whether he will recover on its own or it will progress. Progress होगा तो क्या progress होगा? So you are not treating the patient definitely for this with the immunosuppressive drugs. The
yes,
active
sir.
management,
Definitely.
the
Yeah.
active management in this case is the immunosuppressive drug, be it steroid or something else. If you don't give that, so what will happen to the patient?
So the patient may worsen uh, if the steroids are not given.
Okay, patient may worsen. तो क्या worsen होगा? Already वो worsened है. 4 ग्राम पर डे तो जा ही रहा है और चला जाएगा 5 ग्राम चला जाएगा. वर्सनिंग क्या हुआ? किडनी पे क्या इफेक्ट आएगा? प्रोग्नोसिस क्या है इस पेशेंट की?
Some, it's not a very good prognosis. It depends from case to case, moderate to poor prognosis.
क्या होगा अल्टीमेटली क्या होगा पेशेंट के साथ व्हाट विल हैपन टू द पेशेंट अल्टीमेटली if you not treat it how it will
So
progress
the basically the intra-arterial volume is very low, and the third space loss is very increasing. So there are many complications which can occur, like hypovolemia, syncope, and other complications
ये
due
तो
to the
सिम्टम्स
non-proteinuria.
what will be ultimate fate for the क्या होगा ultimately क्या होगा इस patient को patient will go into CRF
Okay, sir.
okay so he will progress into CRF so this is the stage at we have to give the immunosuppressant otherwise he will once he develop the CRF then there is no regression and then patient will be like in case of CRF only
Yes, sir.
okay okay
Yes.
so any question you want to ask regarding this case from me
So, like after the history, it was mostly presenting as a nephrotic syndrome, uh, maybe primary or secondary. But is there any other DD which can be there? Like I could only find, like the case was only showing nephrotic syndrome and not any other thing.
in this case where you have presented very classically जो history मिलनी चाहिए सब कुछ you have done for the nephrotic syndrome no here and there types na so in this case the diagnosis clinical diagnosis is very
Like
clear that it
straightforward.
is a nephrotic straightforward it's straightforward is a nephrotic syndrome the reason may be primary the reason may be secondary okay
Yes, sir.
and if you don't have the other differential diagnosis so don't speak it. Differential
Yes.
diagnosis can be 1 also, differential diagnosis can be 10 also.
Yes, sir.
But all those 10 or all those your differential diagnosis should somehow fit in the case.
Yes,
Any
sir.
other differential diagnosis in the with this history and examination, I'm not able to find any other.
Yes, sir.
Okay. So
Okay.
if we have only one, just say only one. I have no one. I don't
No.
remember
Yes.
any other diagnosis with this case. With this particularly with this case.
Okay,
Okay.
sir.
Any other case you have? I've asked for 2 cases.
Yes, sir. Like I'm roll for 83, so 81, 82 was supposed to present one case, and 83, 84 was supposed to present the other, but they went on a trek and they're saying that they messaged in the morning only that they won't be able to present the other case.
So they won't be able to present.
No, sir.
Are they in the class?
Sir, I don't know.
What is their name? I will write a complaint to the HOD medicine then. नाम क्या उनके? 81, 82 के नाम क्या है? I remember one name, Josh करके.
Jitendra and Josh.
Okay. I will definitely write a complaint against them. They have not presented. They have not class. They have not joined also. Okay, then any other queries on behalf of your class you can ask me regarding this.
So
See
maybe they've
the
written in the chat box or the question box.
okay. One more question. Would you like to do ascitic tap analysis in this patient? Ascites is there. Would you like to tap it?
So a cytic tap is not generally required, but if it is done, then like it is not generally required. But if the patient is not responding to diuretics and all, then we can try the cytic tap.
Just for the this thing. Suppose this patient came to you and you given the steroids to this patient, and 5 days after your treatment he came with pain abdomen, and you just palpated the abdomen and it is tender.
Okay.
So what will you do then? You got my point. You have started the steroid in this patient, and 5 days after starting the
So
steroid, the
the
patient came to you.
patient may have infection like peritonitis, SBP,
SBP.
spontaneous bacterial
So one
peritonitis.
thing
It is
is
a
that
complication of ascites.
okay, so patient may develop complication of ascites also. For
Yes,
diagnosis part, for, for diagnosis part, ascitic type in this patient is not required.
yes, sir.
Okay. Hmm. Okay. Any other doubt or question you have in your mind?
No, sir.
You will be confident if you get a case like this in your exam.
Yes, sir.
ऑर्थोपनिया की हिस्ट्री ली थी?
क्या sir? I was not able to hear you.
ऑर्थोपनिया की हिस्ट्री ली थी तुमने?
सर डिस्निया नहीं था तो ऑर्थोपनिया की हिस्ट्री भी नहीं
है
ली.
ये क्या बात? तुमने डिस्निया तो एक्सर्शन पे बोला, पर एक्टिविटी पे
So
बोला.
there's no
ऑर्थोपनिया
data
डिफरेंट.
on activity, exertion, or
व्हाट इज
there's no
ऑर्थोपनिया? ऑर्थोपनिया क्या होता है? डिस्निया ऑन लाइंग डाउन.
Yes, sir.
और तुमने क्या हिस्ट्री ली थी? ब्रेथलेसनेस ऑन एक्सर्शन. सो दैट इज
Yes,
डिस्निया ऑन एक्सर्शन. डिस्निया ऑन लाइंग डाउन की हिस्ट्री तुमने नहीं ली. You
yes,
have
sir.
taken
भूल.
history of PND. You have taken the history of PND.
एनडी की हिस्ट्री लिया ऑर्थोपनिया की भूल गई and on exertion की भूल गया.
Okay. Any other thing you want to discuss?
No, sir.
Nothing. So there is no other case presentation today because the other persons haven't presented. It's a
Yes,
very
sir.
good. You have presented very good. And, only thing a
Thank
little things. So we will leave the meeting and thank you to all of you for attending the
thank
class.
you, sir.
Okay.
Thank you, sir.